All right, well, this is going to be take two. I just did about 30 minutes and then the video stopped and went away. So I'm going to try this again. But this time I may do a couple of shorter things and then just piece them together to make sure it posts. First things first, I want to talk about the media assignment. You'll see one on the syllabus is due this coming Thursday. I'm going to push that off a week just to give everybody time. I know some people have had trouble getting textbooks and things like that. So I'm going to update the syllabus. Just want to talk a little bit about that. What I want you to do is go find a news article, video, something in the media, some kind of current event, preferably, but it doesn't have to be current, about something we're talking about in the world of abnormal psychology, psychological disorders. I saw earlier today an article about NBA player Paul Pierce and how his struggle with depression and anxiety and how the isolation of being in this bubble situation is contributing to that, leading to a lot more anxiety, and how the pandemic kind of feeds that in individuals. So the assignment part of it will be for you to write up a summary of what you're watching, share with me a link, or tell me what you're reading so I can take a look at it, how you feel about it, how it relates to what we're talking about. Doesn't have to be long. Probably a couple of pages is way more than you need. So just writing enough to tell me what you're looking at, your feelings about it, and how it relates to what we're studying. The goal here being to connect what you're seeing in the textbook and what I'm talking about with the world around us. There's plenty of examples of psychological disorders out there, and so this is just my way of trying to get you to look at some of that. So let me go back. If you have questions about that, feel free to email me. We're going to be talking this week about assessment of disorders. How do we determine who has a psychological disorder or what we're looking at? And a couple of key factors here when we're dealing with clinical assessment. We want the ability to look at a person, what they're experiencing, and be able to understand that, get more information about that, to be able to predict what that's going to look like long term, to be able to plan an appropriate course of treatment, and then ultimately evaluate whether or not that treatment has worked. That's an effective assessment. Starts like a broad funnel. Essentially, I'm going to ask you a ton of different questions, these generic questions about your background, your history. Like when you go to a doctor's office for the first time, they want to know about your family medical history, your medical history. Have you ever been hospitalized? Do you take any medicine? Do you have high blood pressure? Do you have any parents or family with diabetes or high blood pressure? So they're looking at all this generic stuff, and then they filter down into what your problem is that brought you in. Happens the same way with mental health disorders. We look at this broad range of questions when people come in, historical questions, background, history, where you're from, what your relationship with your parents is like, what your family is like, what's your support network. Then we get into more specifics. What brings you in today? What is your specific concern that brought you to therapy? Tell me about that. And so we start with this broad group of topics and then slowly work our way into what issues we're dealing with. We use that to focus our treatment, figure out a treatment plan, a course of action for dealing with what has brought you in. Sometimes people come in for generic symptoms and they may not have any specific goals in mind, so it's our job as therapists to sort of shape that, to go through and figure out what it is they want to work with and help them, the clients, figure out where they want to go with it and how we can improve their lives. That's the ultimate goal here, is to improve functioning of whoever comes in. So, the most common form of a psychological assessment is just a basic interview. My sitting down and talking to you about what brings you in, what problems you're experiencing, how you see that, and what you want out of treatment. So we start with a clinical interview. The most common is just an unstructured assessment. So my talking about what problems you feel like you have, using that funnel analogy to shape the treatment from there. There are also more structured assessments. If someone comes in and says they have a lot of anxiety, I may use a structured assessment like the anxiety disorder interview schedule. It goes down through the diagnostic criteria for anxiety and helps me focus in on what specific disorder they may have. In mental health, we utilize the Diagnostic and Statistical Manual of Mental Disorders. We're now in the 5th edition of that. It came out, probably 5 years back. And it's been revised several times over the years. It went from being like a 60-page document to now a book of probably close to 1,000 pages that looks at categories of disorders and the specific symptoms that fall under that disorder. For example, if you have a major depressive disorder, here are a list of symptoms that people experience when they have a diagnosis of major depressive disorder. They have trouble sleeping. They feel guilt and hopeless. They have, feelings of worthlessness. They have suicidal thoughts. So as I go down through these listed criteria, I know that based on how other people have responded, if you respond similarly, you probably have major depressive disorder. So it's sort of a categorical approach to looking at symptoms. We also do mental status exams, just a basic, quick, do you know who you are or where you are? Do you know what day it is? You can really do a lot of weeding out for things like neurological disorders by telling if people, by identifying if people are aware of their surroundings, who they are, the date, basic thought process. You can look at intellectual functioning. Are you dealing with someone who is intelligent, at least average intelligence, or someone who has low intelligence? Are you dealing with people with a lot of confusion or who are disoriented or delirious? Because that might shape what we think is going on with a person. If I'm seeing a person who report substance use and then they're having like active visual hallucinations and appear to be disoriented, I may think they're intoxicated or either withdrawing from substances. So that will shape my idea of what is going on with them, the clinical picture. You can also use physical exams as part of the component. There's a lot of physiological links to mental health. For example, things like heart rate and blood pressure can play roles in anxiety. So you might look at things like that. So some of the things, I'll put this PowerPoint up, but we're looking at the rate of speech. We're looking at their mood. And with the intelligence, like the type of vocabulary they use, or they're capable of abstract thoughts. Are they able to repeat objects to me? I give you a list of 3 objects. Can you repeat them back to me? Repeat them again after a few minutes. Just very basic things that most people do easily, but people who are experiencing a lot of dysfunction may struggle with. So that's part of what we use. Also, we can use behavior assessments and analysis. Focus on the present, here and now. What is going on right in this minute? What types of behaviors are you seeing in your child or in yourself? Right here today, can you tell me what your anxiety looks like? Can you rank it on a scale of 0 to 10? What symptoms are you experiencing right now? Are you having suicidal thoughts? So like a present look at the symptoms. And also sort of a direct observation can be part of that. Can I observe you in your natural setting to identify what symptoms are going on? We use this a lot with kids. Kids aren't always the best at telling us what's going on, so sometimes you go into the classrooms or go into places that they normally are, daycares, and you just watch them without them knowing you're watching them. And you get a whole lot better picture of what's going on. A kid may tell you that there's nothing wrong. A parent may say they seem like they're very anxious. But the kid says, oh, there's nothing wrong, I'm completely okay, and they just can't identify what's going on. I can go in and see them in a classroom and see that they're having trouble understanding, they're having trouble paying attention or sitting still, or they're having trouble interacting with peers. And it gives you a better idea just on observing their behavior in a normal setting, what's going on. And that can also help shift the focus. We can do some things like ABCs, which is a part of cognitive behavioral therapy and rational emotive therapy. All things we'll talk about throughout the semester, looking at antecedents, behaviors, and consequences. So the B being the behavior that you're exhibiting that's causing trouble, antecedent being the things that are happening immediately before that, then the consequences being what are the results of your behavior or action. And that can give us a really good indicator of how behaviors are being reinforced. So a child is, the problem behavior is screaming during class, and I may observe them and notice that right before that, some task demand is being put on them. The teacher is asking a question. The result, the behavior is that they're screaming, and then the consequence is that the teacher moves on and says, okay, I'm going to get somebody else to answer that. So that will give us an indication that behavior may be reinforced as a result of the teacher just deciding to move on and not making that kid answer the question. So it can give us an idea of how behaviors are presenting, but also why and sort of the outcome of the behavior to help us shape treatment a little bit. And we'll talk about that specifically when we're talking about anxiety and depression, because I think you see it a lot there, and also maybe childhood disorders. Some of this stuff can be formal, it can be informal. I can give you a behavior checklist, or I can give your teacher or your partner or someone who knows you a behavior checklist and say, okay, here's this checklist. Tell me, I want you to rate Jimmy on these factors. Tell me how does Jimmy deal with stress or when demands are put on him? What does he have problems tying his shoes, or does he have problems interacting with peers? And so I can give these formal ratings to teachers or parents or caregivers, and they can observe you and then report back. I can also do just more informal behavior observation, just kind of watching and observing without any formal checklists or anything like that, just trying to watch. Or having parents or caregivers just report into what they're seeing without any sort of formal documentation. Some of the problems with those types of things is that people know they're being watched. They'll react differently. If a kid knows them in the classroom watching him, they'll respond differently. Any parent can tell you that if your kid knows you're watching them, they're going to behave differently than if they don't know you're watching them. So more indirect or more sort of covert observation, or observation when the child isn't sure if you're watching them or the entire class or just, an aide they're assisting. The goal, you get more reliable information the less people think you're watching them directly. So one of the other assessment tools that we use are psychological testing, and that's a broad category of things that go from IQ testing, intelligence testing, to personality assessments or projective tests like the Rorschach. All of those are examples of things that we use for assessment. So let me jump ahead here. Your one of the examples of projective test. A projective test means this ambiguous question or stimulus is presented and you get a response, and there's no correct response. The example that we all know is the Rorschach ink blot test, and they give you this ambiguous figure, and there's one in the PowerPoint you can look at. Looks like slide 16. And you just like, what do you see in this picture? If people give you a response, and based on that, how other people respond. We make assessments about what people are looking at. You can also use things like asking a kid or a young adult to draw a house, a tree, and a person. What you might see is the way they draw those figures may represent some feelings that they aren't expressing, but have just have sort of repressed. For example, if you draw a picture of a house and, a tree, and like the person is way off on the other side, they may experience some like isolation or loneliness. If you ask people to draw a picture of their family, that can be very telling, the relationship between the people. The problem is it's all subjective and it's not entirely reliable. And there is no really right or wrong answer, so it can be difficult to get an accurate assessment there. We do use some more objective tests, like we use personality inventories. The most popular Minnesota Multiphasic Personality Inventory, the MMPI, I think it's in the 2nd edition right now. It's a group of yes or no questions that measures people on a variety of personality scales, depression, paranoia, introversion, extroversion, things like that. And it's given to individuals to try to get a better idea of their overall personality. It's normed, it's valid, reliable, all of those things you look for in a test, and so it does provide us some pretty useful information. The problem is it's very long, 500 some questions, and even yes or no, people get pretty tired. So you see things like people just half reading the second half of the test, or just randomly filling out answers, and so you have to look for, is this reliable? Are people faking? Are they answering dishonestly? The good thing about the MMPI is it has actual scales that help you distinguish whether or not people are trying to intentionally make themselves look good or make themselves look bad by not answering truthfully. Some of the intelligence tests are some of the more useful assessments that we have as psychologists, but also just useful in general. Chances are if you have issues in school, you're going to have an intelligence test. If you have learning disorders, or they think you may have ADHD or autism, any of the childhood disorders, you're probably going to have an IQ test. A lot of people have had these. IQ tests tend to be, it's a standard measure of intelligence. What you're doing is comparing yourself to other people, same age norms generally. So how do I compare on an IQ test? How do I respond to questions in comparison with other people like me and the same age as me? Generally with those tests, your average is 100. So most of the population falls within one standard deviation, so 85 on the low end to 115 to the high end. Most people are in that range. Anything above that or below that tends to be, very intelligent, or some indication of poor intellectual functioning, developmental disorders, intellectual disability, things like that. And we'll talk about that more towards the end of the semester. But what we're looking here is a comparison of how we do on these things. Typically, it's like verbal and performance indicators compared to people who are like us. Also, there's some neurological testing that is used to look at things like brain damage, or dementia, or Alzheimer's, or any kind of brain abnormality. Testing for sort of a broad range of skills and issues that stem from brain dysfunction. One of the examples in your book is the Luria, Nebraska. Also the Halstead-Ratton batteries, looking for brain damage and just testing skills like grip strength, response to sound, attention, concentration, things like that. We're looking for things that most people can do fairly easily, but people that are having brain issues won't be able to respond to. The problem with some of those is you can have a lot of false positives where you show a problem and there really is none, but also you can have the opposite, false negatives, where you fail to detect a problem that's actually there. And both of those are fairly common with some of those things. Also, we have growing research in the field of like neuroimagery. You can look at MRIs and CAT scans and things like that and see some function of psychological disorders, particularly things like schizophrenia, which have been around longer, so we have more brain scans. But you can look at the brain scan of a normal functioning person compared to the brain scan of a person with schizophrenia and get a fairly good idea of what's going on. Unfortunately, brain scans are really expensive. You don't just go in and get one done, and it's cheaper and sometimes easier to just do a clinical interview versus spending thousands of dollars on a neuroimaging scan. If you really stuck and didn't know what was going on with a person, then that might be a viable option, but realistically, you're only going to use those as part of either something really complicated that you can't identify, or you're going to use it as in research. But there is functional differences in brains of people who are experiencing psychological disorders versus normal neurotypical brains. So we'll look at some of those as we go throughout the semester too when we're talking about the specific disorders, because I think that stuff is fascinating. Also, things like EEGs, measuring brainwave activities, particularly when you're talking about sleep dysfunctions. We'll talk a little bit about that as we go throughout the semester too. EEGs are very useful. We look at things like heart rate and respiration, particularly when we're looking at anxiety disorders or post-traumatic stress disorders. Also, things like headaches and hypertension and sexual dysfunction. All of those we use some psychophysiological assessments. So this combination of looking for psychological disorders and pairing that with physical things like blood pressure, heart rate, respiration, sweating, all of those types of things. So just to roll back a little bit, I mentioned the DSM, Diagnostic and Statistical Manual of Mental Disorders. It is the classification system measure that we generally use. The medical community uses the ICD-10. There's been movement over the years to make those two more similar. And so one diagnosis code meets both, which hasn't always been the case. Doctors tend to diagnose things differently. Medical professionals tend to diagnose things differently than psychological, social workers, whatever. But there has been a movement over the years to sort of move those closer together. Traditionally, we use this categorical approach, where you either have a disorder or you don't. I have major depressive disorder. I meet these criteria. I have to have 5 of the 7 to meet this symptoms, or I don't have it. Now we use more of a dimensional approach. Autism is a great example. You have the autism spectrum disorder. So you have people who are on one end of the spectrum versus the other. People who have symptoms of autism, and then people who have many, many more and more disabling symptoms of autism. So we see a lot of disorders along a spectrum now. And you think about that, you can have mild depression, or you can have severe, can't get out of bed for days, or acutely suicidal depression. Both are still depression, but we have different severities. And so we like to look at that in terms of what we're dealing with, just the overall level of a disorder and how impairing it is. Not to say that people who have milder depression or milder forms of autism, that isn't a problem, because it certainly is. It's still disabling and impactful to their life. But there are some differences in the level of severity that we have to look at. First of all, if I'm treating someone who is so severely depressed that they're acutely suicidal, who won't get out of bed, who don't want to engage with me, I'm going to approach that a lot differently. There are things I'm going to want to take on a lot differently than someone who is getting up, coming into the office, and wants to get help for their depression. So the focus is going to be different. The symptoms may be the same, but the approach is just a little different. Let me go through just the brief history of the DSM. I'm getting really paranoid because this is about the point last time where things cut off. The DSM started in 1980. It was very brief, just sort of a brief category, a list of potential disorders, and it had a 5-axial system, which I'll talk about in a second. Several evolutions over the years. The DSM-4, which was the one that I used most of my career, began in 1994 and started to really expand the look at different disorders. And then there was a revision of that, and there was a 5-axis system. Axis 1 was your primary mental disorder, Axis 2 personality disorder, or at the time mental retardation. Now we don't use that language. It's intellectual and developmental disabilities, but at the time that was the diagnostic criteria. Axis 3, general medical disorders that can impact a disorder. For example, if you have Alzheimer's disorder, that may impact your mental health as well. If you have heart disease, that may impact. Axis 4 being social determinants or factors, stressors. Like I lost my job, I got divorced, I had, I have a lot of trouble at work. So social factors, environmental factors that may play a role in your symptoms. And then the third, fourth, fifth was just a number, generalized assessment of functioning, so a GAF score, 0 to 100, which gave a quick look at how you're functioning. The DSM-5 eliminated that, removed the axial system, which I thought was really not a great idea, because I think some of those other factors are kind of critically important to identify stressors and all that, but just become more focused on the particular, sort of combine the Axis 1 and Axis 2 disorders and focused on the actual psychological disorder part of it without getting into the rest quite as much. One of the problems we see is that people have more than one disorder. People that have, and that's referred to as comorbidity. So people who have anxiety disorders also tend to be at higher risk for depression. People who have substance use disorders have higher rates of depression and anxiety, and vice versa. People who have one personality disorder, like a antisocial personality disorder, also have symptoms of narcissistic personality disorder. So there's a lot of comorbidities when we're talking about diagnoses. And so one of the things that the DSM-5 looked at was fine-tuning some of the diagnostic requirements to try to eliminate some of that. Not necessarily because we don't believe there's comorbidities, but maybe our disorders or diagnosis criteria just weren't good enough and weren't accurately capturing things that were distinct. So we still know that there is a lot of comorbidity and a lot of people have more than one disorder, but we want to look more at making sure the diagnoses were accurate. Still, we deal with issues like labeling. Giving people a disorder inherently makes it more likely that that disorder follows them, and makes it more likely that people deal with the stigma of psychological disorders. If I say that you have a personality disorder, that shapes the way other professionals are going to see you, because there's a distinct list of symptoms and things that are unique to that diagnosis that other people see when they see you. A doctor's reading your chart and says, okay, Billy has antisocial personality disorder. He has all of these symptoms. It's disobedience to authority. He doesn't like to take responsibility for what he's doing. He has no regard for social norms. So all of these criteria that come along with this. Or Mary has major depressive disorder, so she's probably really sad and has trouble sleeping and doesn't get along well and doesn't want to do things. So the disorder really follows you through, and it is important that you get it as correct as possible. And I mentioned earlier that can kind of be a problem when insurance companies are pretty limiting. Your insurance company generally is going to approve you for 8 or 10 sessions to work on your psychotherapy. Gone are the days when we can just open-ended go to a therapist for the rest of our lives if we want to and just kind of mess around. You have to have empirically validated treatment. I have to prove to my insurance company that I'm using a treatment that actually works and isn't just something that I thought up. And it's like, you don't want to deal with experimental medicines that haven't been approved. It's the same way in mental health. Your insurance company and like utilization review folks are going to look to make sure that what I'm doing is proven to be effective and is working for you. And they're going to check that on an ongoing basis. So definitely something to keep in mind when you're talking about therapy. And I may have mentioned in this video, or the one that I lost, that I'm not going to talk about the last part of this section, which is research. Not because it's really, it's not terribly exciting stuff, but I also just think I would rather talk about it when we're talking about the specific disorders. I think it fits better there. So I'm not really going to go that much into that. A couple of things I'm going to do. I am going to post a video of a therapy session because we're talking about clinical assessment and the importance of figuring out what's going on. I want to for you to see that in action and be able to see this video. It's not terribly long. There are a couple that I may post, but I want you to watch this and kind of look how a clinical assessment occurs. Also, we have your weekly assignment. I'm going to post. I've thought several different things, so I'm going to post something probably tomorrow with more details about what that is going to be for the week. If you have message board things kind of floating out there, if you haven't responded, please do so. I think the thing where we're supposed to respond to people and drop them from the course if they're not participating, maybe this week. And so I'll look, and if there's anybody who hasn't responded to anything or signed in or logged in, I'll drop them. You're probably not watching this video if that's the case, so whatever. And I'm going to try to figure out before next time why the video cut off halfway through so that doesn't happen again. But in any case, so this is shorter than I planned on because I cut out a bunch of stuff and then really forgot what I said when I went back, but it works out better for you. So just to recap here, I want you to, the media review will be due, I'm going to extend that out a week. Feel free to turn in early. It'll make me happy. I can go ahead and get it graded. You can just email those to me. I'm going to try to fix the thing on the Blackboard where you can just drop things in there, but for now, just email those to me because I've been having trouble with that. I tried to send myself something there, but it didn't go. So just email to me. It doesn't have to be very long. No more than a couple of pages. Send me the source. You don't have to do APA or anything like that. Just like literally send me a link. If you have any questions or anything, please let me know. Hope your semester's going well so far. Things are continuing to move along. It's all this stuff's kind of work in progress, so I hope your classes are going well and things are relatively no more stressful than they would be anyway. But if there's anything I could do, you have any questions or comments or any ways we can make this better, please let me know. I will post the Blackboard slides here. These things take forever to upload, so I'll post those probably before I actually post this video. Have a good week, and I will see you later. Thank you.